Now for KRAS and BRAF, we now have targeted therapies. KRAS was often considered undruggable, and it was considered undruggable because if you inhibited the RAS protein in a mammal or a human, then all the cell signaling would stop in all the cells of the body, and all the cells would die. Effectively, would be like a poison. But the folks at Amgen and a variety of other pharmaceutical companies now have developed drugs that only inhibit RAS if there's a mutation in RAS. So only if it's a broken RAS will it be inhibited. And if it's a normal RAS, it won't be inhibited very much at all. And these drugs really generate remarkable responses. And it's just like what you see with all of the other very exciting oral tyrosine kinase inhibitors in all the other presentations, where we see the vast majority of patients seeing their tumor shrink. And so here I'm showing you data from sotorasib and adagrasib, which were the first two drugs that came to the market and are the currently two only FDA-approved drugs, where you see most people's tumors getting smaller rather than bigger once they start the drug, and that's what these waterfall plots show. The target has now been evaluated by a number of other pharmaceutical companies, and we're now seeing mutation-specific inhibitors from lots of other folks. Now, because they're mutation-specific, they only work against a very specific KRAS mutation. So in the case of sotorasib and adagrasib, they don't work against all KRAS mutations, only the KRAS G12C mutation. So it's a change in amino acid number 12 from a glycine to a cysteine. Only if that's the mutation that caused the KRAS to be abnormal will these drugs work. Now, there's other companies working on inhibitors of KRAS G12D. There's other people who have inhibitors that work against lots of different mutations. So they work against more than one mutation. These are all going to be new developments that are going to be very exciting. Now, the thing is, these two drugs don't mix well with immunotherapy. And the combination of the two can be problematic because people can get liver inflammation from these drugs, and they can get liver inflammation from immunotherapy also. And so when you mix them together, they just don't mix well. There are people who are working on drugs that don't cause as much liver problems that may be mixed better with immunotherapy. And so we're really looking forward to seeing offerings from other pharmaceutical companies in the future that have that characteristic. Now, for people with BRAF alterations, there's actually a couple of different FDA-approved combinations. The thing with BRAF that's kind of funny is if you just inhibit BRAF, a compensatory signaling pathway in a gene called MEK will turn way up, and the patients will actually start to develop growths of cells kind of on cell surfaces, on their skin and other places in the lining of their airways. That's problematic. So you don't want to inhibit BRAF by itself. You always have to inhibit MEK every time you inhibit BRAF. And this means that when you're taking a BRAF inhibitor, you're also taking a MEK inhibitor. Now, the first combination of BRAF and MEK inhibitors that were approved in lung cancer were the combination of dabrafenib and trametinib. There's also another combination that's been more recently approved, encorafenib and binimetinib. And they work very similarly, a lot like Coca-Cola and Pepsi-Cola. They're more alike than they are different. But here, again, you see a lot of patients who take this combination very profoundly see their tumor shrinking. Now, the biggest problem with this combination, of course, is it causes fever. It's kind of weird, but that's what it does. And that's troublesome to patients. People don't feel well when they have fever. So they actually oftentimes have to take Tylenol just around the clock 3 times a day to suppress fevers. And it can be a little scary at first because people are used to when they're having fevers thinking that they might have an infection. but these fevers aren't caused by an infection. It's just that the drugs change your body's temperature set point, make you hot, and run a little hotter than what you would otherwise run. And that's really, I think, the biggest management challenge for people on these drugs.